You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for May 16th, 2025. This week, the BedMed trial of nighttime blood pressure meds, the SURMOUNT-5 trial, troponin upper reference limits, gene test in patients with no disease, and guideline-directed medical therapy for heart failure. First topic is the timing of blood pressure meds. JAMA has published what I hope is the last of the trials of timing of blood pressure meds. Here is a brief rundown of the history. The MAPEC trial, M-A-P-E-C trial, conducted between 2000 and 2009, found a 61% reduction of MACE, favoring bedtime administration of blood pressure meds. This was published in a journal called Chronobiology International. I know, I had never heard of it either. Then, the same group from Spain conducted the HYGEIA trial of 19,000 patients with hypertension, and they reported a 45% reduction in MACE with bedtime blood pressure meds. The European Heart Journal published this trial in 2020, and it set off a storm of controversy. The European Heart Journal editors even issued a formal expression of concern letter. Ricky Turgeon and Canadian colleagues writing in the American Heart Association journal Hypertension noted that the main concern of many concerns with HYGEIA was that nighttime blood pressure meds also reduced the risk of non-cardiovascular death. This, they argued, was a serious outlier, as no blood pressure trial had ever shown a reduction in non-CV death. Further, Turgeon et al. Noted that it was unclear whether or not HYGEIA was truly randomized, nor whether allocation was concealed. Then came the TIME trial, which enrolled 21,000 patients with hypertension in the UK, and these authors found no difference in MACE depending on the timing of meds. Lancet published that study in 2022. The BedMed trial, published this month in JAMA, was a study of 3,500 Canadian patients with hypertension recruited from primary care clinics. Half got morning meds and the other half took their meds at night. There was absolutely no difference in MACE outcomes over a nearly 5-year follow-up. My comments. I believe the TIME and BedMed trials disprove the findings from the single group in Spain. My reasoning is simple. The findings of a massive MACE reduction simply by changing the time of day of blood pressure meds is implausible. I especially struggle with HYGEIA's reduction in non-CV death. Then, in two separate geographies, two independent groups find no benefit depending on the time of day. I think you go with the plausible results in the two trials, TIME and BedMed. Now, another lesson from this story is the matter of open data. Here, I don't single out the HYGEIA authors because I feel that all RZTs whose results could change practice ought to be submitted with source data so that it can be independently verified. Think of the time and money that it took to disprove implausible findings. TIME enrolled nearly 21,000 patients, and BedMed enrolled 3,500 patients, and both trials followed patients for MACE for approximately 5 years. I think we need to learn that trials with massive effect sizes deserve both our attention and our scrutiny. I hope the new leaders at NIH and FDA emphasize replication of studies. Now, the message for our patients with hypertension, it is simple. It does not matter what time of day you take your meds. Just take them. Todos los días. All right, second topic, Tirzepatide versus Semaglutide. The SURMOUNT-5 trial. New England Journal of Medicine published the SURMOUNT-5 trial of Tirzepatide versus Semaglutide for weight loss. The manuscript in New England is long. The statistical method section is long, like 3 paragraphs. The discussion is also many paragraphs, but I don't understand why this is so complicated. These patients were non-diabetic, age 45 years, 2/3 female, and an average BMI of 39. One group got Tirzepatide, the other Semaglutide. The primary endpoint was simply a change in weight from baseline, and Tirzepatide easily won. Over the 72 weeks of the trial, those in the tirzepatide group lost 20% of their body weight versus 13.7% loss in the semaglutide group. Those in the tirzepatide group were more likely than those in the semaglutide group to have reductions of at least 10%, 20%, and 25% of body weight. Secondary endpoints, which are important here because they're cardiometabolic risk factors like blood pressure and glucose, were also lower in the tirzepatide group. Systolic blood pressure reduction was 10 millimeters of mercury versus 7.7 in the tirzepatide versus semaglutide groups, respectively. The safety signals were similar. So my comments, as most know, tirzepatide is a dual GIP and GLP-1 agonist. Now, whatever is the mechanism, and authors speculate a lot, tirzepatide induces more weight loss with a similar safety signal. I'm not sure it matters what the mechanism is. Semaglutide has been shown to reduce more than weight, though, right? In the SELECT trial of patients with established atherosclerotic vascular disease, semaglutide reduced MACE outcomes by about 20% versus placebo. SURMOUNT-5 authors tell us that there is an ongoing cardiovascular outcomes trial with tirzepatide. But I would speculate that the cardiovascular disease modifying effect is a class effect. Now, the purists may say we need more data because weight loss is still a surrogate measure. I don't know. The more weight loss we get, especially when starting at a BMI of 39, seems like the better. Systolic blood pressure, too, was lower with more weight loss. One caveat was that the trial was open label, which is weird, right? Because surely the sponsor, Eli Lilly, could afford proper blinding. I mean, I guess it's possible that if you know you are on the stronger drug, tirzepatide, you might do more to lose weight regarding diet and exercise. As for clinical translation, I think I would reach for tirzepatide first. I mean, why wouldn't you go for the more potent weight loss drug? Thing is, there will surely be more GLP-1s coming to market, and the tirzepatide lead may soon be taken away. All right, third topic today is the matter of age-specific troponin upper reference limits. Irish cardiologist Mark Coyle and John McAvoy have argued persuasively in the European Heart Journal that the coming fifth universal definition of MI should include age-specific high-sensitivity troponin upper reference limits, or URLs. I did not know that another universal definition of MI was coming soon, and whenever I think of high-sensitivity troponins, the following sentence comes to mind. That is, it should not be so, but the increasingly sensitive troponin assays make life more complicated. I say it should not be so because Andrew Foy and I have explained in JAMA Internal Medicine how to use troponins at the bedside. The teaser is that it's no different from CPK, and that you have to think first about whether the patient with an elevated troponin is having a plaque rupture MI. If they are not, then you treat the underlying cause. Really, it's that simple. Now, the two writers make a compelling case for having age-specific reference values. I'm sure you have all seen older patients with troponin levels just above the reference. This too should not be so, but those red values for abnormal in the chart, they infect our brains. It does mine at least. I hate seeing those red numbers in the EHR. Now, before I tell you their argument, I want to ask a common sense question, and that is, why should a 75-year-old have the same normal value as a 25-year-old? It makes no sense. Coyle and McAvoy write an extremely compelling argument. It's structured, it's well written, it addresses both the pros and cons of having age-specific upper reference limits. You will learn a lot reading this manuscript. I'll give you a brief summary. They first tell us why troponin upper reference limits are used to define myocardial injury in the first place. You need these URLs because troponin levels are not standardized across different manufacturers of troponin assays. Thus, there is a need for a common benchmark of abnormality for all troponin assays. They then explain how URLs are derived. Basically, you measure troponins in a sample of normal adults without disease. The reference population is 400 adults. Why 400? I don't know exactly. They say for statistical purposes. Now, with this group of 400 adults with troponins, you can calculate a value that is the 99th percentile. This is the upper reference limit. Now, with that as a background, the authors tell us of efforts to derive the 99th percentile troponin levels for the U.S. population using longitudinal data such as that in the NHANES study. Now they're getting close to making their specific case. The efforts to define upper reference limits in the U.S. population found significant differences in the URL by sex. And indeed, there are sex-specific URLs in the fourth definition of MI. But they also found significant differences by age. For instance, adults aged greater than 60 had consistently higher URLs for high-sensitivity cardiac troponins than adults aged 40 to 59 or 18 to 39 years, and they found a clear age gradient. Now, there was little data on 70 to 80-year-olds, so the age cutoff proposed is over 60. The authors write, quote, "We believe that the use of age-specific high-sensitivity cardiac troponins upper reference limits to define myocardial injury could have major clinical advantages." Now, obviously, the number one advantage is to avoid huge downstream workups for older adults with levels just above normal. The authors rightly argue that a good understanding of troponins would not lead to low-value workups for mildly abnormal lab values, but since they are clinicians, they take a pragmatic approach and write, quote, "We think it would be more impactful to implement age-specific upper reference limits as was done for sex-specific troponin upper reference limits." Now, the next part of their argument in the paper is brilliant. They go through, in a bullet-type format, 7 con arguments against and rebut each. I won't go through all the con arguments. Suffice to say, they persuaded me. Their case is strong. Now, I wish that such age-related normals weren't needed. I wish every doctor who uses troponins understood the test, but since that is not so, helping us with age-specific levels seems like a sound idea. All right, next topic is return to play for gene-positive, phenotype-negative athletes. Jackie P. has published a paper from the Michael Ackerman Mayo Clinic Genetic Heart Rhythm Clinic. The topic of gene-positive, phenotype-negative people could not be more relevant these days. More and more, cascade screening of family members of a patient with genetic heart disease is picking up people with the same gene but no disease. No disease as in no QT prolongation, no ARVC, no hypertrophic cardiomyopathy, etc. Yet these people, now notice I am using the word people, not patients, are often disqualified from sports participation. Mayo Clinic is one of the largest genetic heart disease clinics worldwide, and their retrospective chart reviews teach us a lot. Because, of course, there are few, if any, clinical trials in patients with genetic heart disease. Now, before I tell you the results of this report on 274 gene-positive, phenotype-negative people, let me first say that I consider disqualification from sports participation one of the severest restrictions we dole out. I love sports, and I owe some of my success as a doctor to my years of team sports. Had I had a funny gene and been disqualified, it would have been quite bad. Now let's talk about the study particulars. Patients were considered gene positive if a genetic test identified a pathogenic variant or likely pathogenic variant in an established gene that was associated with long QT, hypertrophic cardiomyopathy, CPVT, or arrhythmogenic cardiomyopathy. Phenotype testing was done with a simple ECG imaging test or exercise test. Of the 274 total patients, most had long QT syndrome, 84%. 7% had CPVT gene, 5% had arrhythmogenic cardiomyopathy gene, and a few percent had HCM genes. The age of diagnosis was 10 and 15 years, mid-20s for arrhythmogenic cardiomyopathy. Most of the people in this cohort study were discovered via family or cascade screening. Nearly 1 in 5 had sought return to play after disqualification at another institution. All but 270 of 274 patients were eventually allowed to return to play after an evaluation or guideline-directed treatment and shared decision-making. For the long QT syndrome, individuals who were truly disease non-penetrant were treated mostly with pharmacologic therapy, that's 72%, or what they call INT, Intentional non-therapy, this was 25%. Now, intentional non-therapy consisted of avoiding QT prolonging drugs, advice for proper hydration, perhaps acquisition of a personal AED, and routine follow-up visits. The small remainder of people were treated with more invasive therapies such as left cardiac sympathetic denervation, that was just 2, or an ICD in 3. 2 of the patients with an ICD had the device placed before being seen at the clinic. For CPVT, or catecholinergic polymorphic VT, after evaluation, most people with this gene were treated pharmacologically, that's 58%, or with an INT, intentional non-therapy, 43%. For arrhythmogenic cardiomyopathy, which, as you know, is a peculiar condition where the ARVC, the fatty infiltration of the right ventricle, the phenotype can be exacerbated by chronic endurance exercise. In this case, all individuals were put on a plan of active surveillance to monitor for any evidence of phenotypic conversion or disease emergence. All cardiac imaging in this group was normal, including cardiac MRI, and patients had no structural evidence of disease. On follow-up, 2 people showed late gadolinium enhancement on cardiac MRI 4 and 5 years after the initial Mayo Clinic visits and were considered phenotype positive at that point. For hypertrophic cardiomyopathy, gene positive, all individuals were managed with INT, intentional non-therapy. They were all referred for evaluation because of a positive family history for the disease. So what were the outcomes? Overall, in total, 68% of the gene-positive, phenotype-negative people received pharmacologic therapy, and 27% received intentional non-therapy. And no patients had any disease-related cardiac events or deaths in more than 1,300 years of combined follow-up. No patient, none, nada. Now, what about pathogenic downgrades? About 60 patients had their gene variant downgraded from pathogenic, likely pathogenic, or variant of uncertain certainty to likely benign. These patients were not included in the 274 in this report, but I include this because it's an important data point, because these patients were disqualified at the same rate as the patients with the true pathogenic gene variants. My comments. This is a really important paper, really important. I get gene reports and they are scary, right? For 2 reasons. First, because no one wants to have a young person have cardiac arrest. Second, because almost no one knows much about genetic heart disease. Indeed, gene testing is about as opposite from troponin testing as it gets. Cardiologists deal with troponin levels every day. We have a feel for troponins. It's often the wrong feel, but there is at least familiarity. Gene reports come with this bold-faced phrase, pathogenic variant, and our tendency is to pull the trigger and say no sports. What this report from Mayo tells us is that if you do a proper evaluation, history, exam, ECG, image, and stress test, you can identify phenotype negative people. That is, they don't have any disease. And then you can set forth a treatment and follow-up plan, often with no treatment. These people, not patients, can live normal lives and participate in sports. Now, the authors write with caution, quote, "In fact, the purpose of this study is not to encourage physicians to disregard a positive gene test, but to use it as a tool to further risk stratify and guide management and treatment of the patient, and to not automatically disqualify from exercise." For instance, the INT strategy, the intentional non-treatment, the authors write that even though no prescription is given or intervention performed, avoidance of QT prolonging drugs, being proactive with electrolyte replenishment and hydration, monitoring other variables that could lead to an event, for instance, lack of sleep, excess caffeine, the postpartum period, and attending frequent follow-ups are still expected. Now, I realize that you and I will not ever become experts in genetic heart disease from reading this paper, but reading this paper should infuse us with perspective. That is, genes are not fate. Genotype is not phenotype. Disqualification is severe, and when we find gene-positive people, the answer is not to scare them and disqualify them from sports. The answer is to read, research the problem, and as I often do, phone a friend. Then, once you have done that, have a discussion with the person and their family. I want to say thank you to Dr. Michael Ackerman and his team. They have taught me and the entire field of cardiology tons about genetic heart disease. The final topic today is about rapid titration of guideline-directed medical therapy in heart failure, and it will focus on the STRONG-HF study. Well, here we go again with rushing guideline-directed medical therapy. JACC Heart Failure has published a research letter in which numerous authors performed a post-hoc analysis of the STRONG-HF trial. The main study question was to quantify how many days free of death or heart failure hospitalization over 6 months is gained with rapid up-titration of GDMT after an admission for heart failure. The secondary aim of this post-hoc study was to promote the endpoint of RMST, restricted mean survival time, and RMSTD, or the restricted mean survival time difference, which the authors say provides a direct measure of clinical benefit and can complement the hazard ratio. Now, it's interesting because in years past, trial reports often included such a measure. For instance, in the AVID trial of ICD versus antiarrhythmic drug therapy for VT, the average unadjusted length of additional life associated with ICD therapy over antiarrhythmic drugs was 2.7 months at 3 years. Now, I'm not sure why authors stopped including such data points in their manuscripts, but one theory is that it seriously minimized the differences. Now, back to the STRONG-HF substudy and the matter of, quote, rapid up-titration of GDMT. Remember, STRONG-HF was published in 2022. It enrolled about 1,600 patients with acute heart failure who were not treated with optimal medications from 87 hospitals in 14 countries. Nearly 90% of patients in this study were recruited from Africa and Russia. Patients were randomly assigned to a high-intensity treatment arm or usual care. Now, the high-intensity rapid treatment arm was aptly named. Patients first were given half the optimal dose of heart failure meds while still hospitalized. Now, these included all the usuals: renin-angiotensin blockers, beta blockers, MRAs. At week 1, after discharge, patients were checked for tolerance of these meds. At week 2, meds were up-titrated to full dose. The week 3 visit was used to check tolerance of the full-dose meds, and then patients were checked again after 6 weeks. Notably, cardiologists performed these safety visits using only a history exam and measurement of basic labs. The usual care arm was according to the local practice in Africa or Russia. Now, obviously, the high-intensity arm did better. They had 5-fold more frequent in-person visits and far more patients taking optimal heart failure meds. The primary endpoint of death or hospitalization for heart failure at 6 months was 34% lower in the high-intensity arm. Readmission for heart failure drove the benefit, but all-cause death was 16% lower, and CV death was 26% lower in the high-intensity arm. The trial was terminated early for benefit. Adverse events actually were higher in the high-intensity arm, 46% versus 29%, most commonly related to low blood pressure or hyperkalemia and renal issues. I wrote about STRONG-HF in 2022, and I wondered if it would change hospital systems. That is, if you found a way for a cardiologist to see the patient 4 times in the 6 weeks after hospital discharge, you could improve outcomes. Well, since STRONG has come out, I have heard little about hospital systems changing their protocols. But, perhaps I was naive back in 2022. Now, the guideline-directed medical therapy enthusiasts used the STRONG-HF study to promote the value of rapid titration of meds. I now, however, have come to recognize STRONG-HF as one of the classic examples of performance bias, which infects so many strategy trials. That is, patients randomized to the high-intensity care get a lot more than just rapid titration of meds. They have 5-fold more interactions with doctors and heart failure teams. They had more education, more follow-up, and simply stated, more care. Now, there is no way to tell if it was all the extra care or the meds. I can't think of any examples of situations where you give one group of sick people 5 times more healthcare interactions than the other group, and it doesn't matter. In fact, this is the reason the East-AF trial found benefit for early rhythm control. In East-AF, there was little difference in sinus rhythm between the early rhythm control and rate control arms. so rhythm control couldn't explain the better outcomes. Instead, the early rhythm control had tons more healthcare encounters. I know, that was a long intro into this research letter looking at days free of the primary composite of death or hospitalization for heart failure. In STRONG-HF, it was nearly 9 days longer without an event in the high-intensity arm compared with the usual care arm. The hazard ratio was 0.61, or a 39% reduction. Most of the benefit was driven by a reduction in heart failure hospitalizations, but the difference in death was 3.5 days, but this did not reach statistical significance. The authors then do a similar analysis looking at extra days free of the primary endpoint based on the percentage of optimal dose of heart failure meds, and of course, patients on optimal doses of heart failure meds did better. Each 10% increase in percentage optimal dose of GDMT was associated with an RMSTD of a positive 1.7 days, and this was statistically significant. Now, the authors are impressed. Quote, "Our post-hoc analysis of the STRONG-HF trial highlights the magnitude of benefit from rapid GDMT up titration in heart failure patients beyond reduced risk. RMST complements the hazard ratio and risk differences and can enhance the physician's ability to convey the real-world impact of interventions to patients and families. Quote, therefore, we believe the RMST should be considered for routine inclusion among clinical trial results reporting. They say that this can potentially bridge the knowledge gap between clinical trial results and bedside decision-making with patients and their families. Unlike hazard ratios and risk differences, which address the critical question of whether a treatment works, the RMST provides a tangible and intuitive answer to the question, how many extra days does this treatment offer? So my comments. I like the idea of using the RMST, but for 100% opposite reasons. I'm not sure where the authors practice or what their patients are like, but here in Kentucky, if I tell a farmer from Grayson County, Kentucky, that if he spends 4 extra days of his life in the next 6 weeks driving to Louisville to see a cardiologist, running through the paperwork gauntlet each time, then taking extra meds, many of which are costly, that he may have an extra 8 days before having another heart failure hospitalization, I'm not sure that he would be interested. It's the same with the AVID trial. Would the ICD have gained their lofty status if we had emphasized the extra 2.7 months of life over 3 years? What do you all think? I think we should use something like the RMST, but I'm afraid it would make a lot of our highly valued recent breakthroughs look relatively modest. For perspective, let's just compare the RMST to a basic old pacemaker. The RMST for a pacemaker for a patient with heart block is likely infinity. The patient dies without the pacemaker and lives perhaps 2 decades with it. I guess the value of using RMST is an empirical question, one that could be evaluated in qualitative studies of what patients think, and I think this would be a great avenue for research. So that's it for This Week in Cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to write us a rating, give us a review. These things help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.